Welcome to the new topic on hyperandrogenism. In this particular section, we'll be discussing on the pathophysiological principles and the etiological principles behind hyperandrogenism. At the same time, we'll be discussing on one of the most important clinical disorders in practice, that is PCOS, polycystic ovarian syndrome. We'll also be closing down the chapter with the discussion of secondary amenorrhea, which is also very important for your exams, and evaluation of secondary amenorrhea is one of the key things that you have to note as far as exams are concerned. So let us go back and start with the pathophysiology of hyperandrogenism. First of all, we have to know about the sources of androgen in a female. We know that there are two principal sources of androgen in a female. One is the ovary, which contributes to approximately 40 to 50% of the androgens circulating in a female, and the adrenal glands, which contribute to 50 to 60% of circulating androgens in a female. As you understand, most of the standard books are going to give 50-50 respectively for the ovaries and adrenal glands, even though certain books go a slight importance towards the adrenals as a major source of androgens in a female. But for all practical purposes, let us assume 50% of androgens from the ovary and 50% of androgens from the adrenal glands. It doesn't only correspond to the blood, but also corresponds to the urine as well, where 50% of the androgens that are in the urine are contributed by the ovary in a female, and 50% of the androgens in the urine in a female are contributed by the adrenal glands as well. So how they do produce and what are the basic steroidogenic principles we have discussed already, but let me tell you in a nutshell. You have an ovary which has something called theca cells, which is going to respond to luteinizing hormone from the pituitary. And these theca cells in response to LH are going to produce androgens. And the most important androgen that is produced by the theca cells are the androstenedione. But remember, females cannot produce powerful androgens like testosterone. Only males can do that. And similarly, the adrenal glands have a very important area called zona reticularis, which is going to respond to ACTH from the pituitary. And they are going to produce androgens, and the most important androgen that is produced by the adrenal gland is the DHAS. Usually they produce DHA in the sulfated form called as DHAS because of their high activity of this sulfonyl transferase enzyme in the zona reticularis. But anyways, DHAS is a little less active compared to that of DHA. But nevertheless, both androstenedione and DHA are weaker androgens, which can be actually converted to most potent androgens like testosterone in a female in the periphery. But this amount of production of testosterone in a female is generally likely to be very, very less, because the testosterone that is produced in the females usually done peripherally, which means it's peripheral conversion by enzyme called 17-beta HSD, which is predominantly seen in the adipocytes. This also gives rise to a clinical correlate that people who are obese are associated with hyperandrogenism. They produce more testosterone. It makes a lot of sense, isn't it? Because adipocytes contain the 17-beta HSD, they are going to convert more of this weaker androgens to potent androgens like testosterone in a female if they are obese. But remember, obesity has multiple complex physiology because they have aromatase enzyme also, which can convert testosterone to estrogen, which can happen in a male. But anyways, depending on what is more, they will be converting that particular substrate to another product. So in this condition, in a female, if they are obese, they are prone for developing hyperandrogenism because they have 17-beta HSD activity. Further compounding the fact, when patients has insulin resistance and hyperinsulinemia, this insulin can actually stimulate the 17-beta HSD enzyme, producing more and more testosterone and hyperandrogenism. Let us discuss that later on. But anyways, right now you have to understand obesity is a cause of hyperandrogenism. But it's also worth noting the fact that this obesity-related hyperandrogenism is more of a peripheral hyperandrogenism. You can understand the word, it's peripheral hyperandrogenism, and this should not be confused with a lady who is having a PCOS, because PCOS is more of a ovarian cause of hyperandrogenism and not a simple peripheral cause of hyperandrogenism. Incidentally, most of the PCOS ladies are actually obese, and that doesn't mean obesity is the reason for hyperandrogenism here. In patients with PCOS, the ovaries are inherently dysfunctional, and it's an ovarian cause of hyperandrogenism, and the obesity just compounds the effects of this ovarian dysfunction by producing more and more hyperandrogenism. We have to be clear in that. And the importance of understanding this physiology also lies in the fact that when you are going to use investigations to differentiate between adrenal hyperandrogenism and ovarian hyperandrogenism, this DHAS becomes a very important diagnostic test, because a patient who's having an elevated DHAS, I'll be going towards the adrenal cause of hyperandrogenism. A patient who's having hyperandrogenism but a normal amount of DHAS will usually go towards the ovarian cause of hyperandrogenism. Similarly, this ACTH and LH principles are also the key, because the dexamethasone suppression test, if they are responding to this DEXA suppression and if there is a DEXA suppression of androgens, it goes towards the adrenal cause of hyperandrogenism. And there is another test called GnRH test. So when you do a GnRH test, if the androgenism is responsive, then you go towards more of a ovarian cause of hyperandrogenism. Clear? So that is the principle of these tests, and it's very important to understand the physiology to know about this testing as well. So now let us go on and discuss the pathophysiological principles of PCOS. Understanding the pathophysiology of PCOS means you are going to have a grasp of idea of the entire hyperandrogenism, because it's the basics of everything. It's the most common cause of hyperandrogenism in a woman. Fine. So first of all, I would like to substantiate the fact that PCOS is an ovarian cause of hyperandrogenism, and it's not just a simple peripheral hyperandrogenism. Here the ovaries are basically dysfunctional. So there are multiple hypotheses and as well as evidences accumulating for the fact that PCOS is no longer considered as an acquired condition. It is more of a born condition, which means these girls are born with PCOS, which means it is too early to call it as a congenital or a heritable condition. We don't want to call that, but we can tell for sure the fact that these girls who are prone to develop PCOS in the later life, or who are developed PCOS in the pubertal or adult life, are already born with PCOS. Clear? So that's what I want to substantiate. They are born with PCOS and it's no longer considered as a acquired condition. There are a lot of evidences to convincingly say this point. So what are the reasons to develop this PCOS or to be born with PCOS? First of all, these girls generally tend to have an ovarian dysfunction. And if you ask what is the ovarian dysfunction that these girls generally tend to have, they are inherently prone for anovulation. And second thing, they are inherently prone for developing hyperandrogenism, because these theca cells are hypersensitive or hyperreactive in these girls, which means they are hypersensitive to LH. And if you culture these theca cells of these girls who are prone to develop PCOS, and you can see these theca cells are basically hyperreactive and they're going to produce more amount of androgens for a given amount of luteinizing hormone. So that is the reason why they're going to produce hyperandrogenism, and they're going to produce more androgens by default. And anovulation itself is one of the causes of hyperandrogenism. We'll discuss that later on, how anovulation can cause hyperandrogenism through progesterone mechanism. But let us see the second important principle behind this development of PCOS, that is hyperinsulinemia. Remember, these girls are basically prone, if not born with hyperinsulinemia, but they are prone for hyperinsulinemia by birth. There are multiple reasons for that. First, let us consider why these girls should develop this ovarian dysfunction. So there are certain things that have been linked to this ovarian dysfunction. One is the paternal obesity. How paternal obesity affects the ovaries is unknown. Maybe some underground genetics may be the case, but remember, it's paternal obesity that has a role in ovarian dysfunction and development of PCOS later, not maternal obesity. And second one, there are a lot of genetics that are going to play in this regard. Genes like DND4A, and there is 70% association with regards to PCOS and obesity. So that is the reason why a lot of genes have been considered to have a role in PCOS, but none of them have been concretely proven to produce PCOS. But still, you have to understand that fact. But one important thing that relates both hyperinsulinemia as well as ovarian dysfunction is an interesting hypothesis that the prenatal undernutrition. You should not call it antenatal undernutrition, because antenatal is the word given to the mother and prenatal is the word that is given to the child usually. So the prenatal undernutrition is generally likely to play a very important role in both ovarian dysfunction as well as the hyperinsulinemia. Why? Undernutrition is going to play a role. For this, you have to understand the evolutionary principle. What is the evolutionary principle? Like our bodies and every single cell is normally programmed to conserve energy rather than spend energy. The usual ideology of a particular cell is towards conserving energy rather than spending energy unnecessarily. This is because energy is not something very easy to get from evolutionary perspective, even though from a civilized perspective of humans, food is very easy to get, at least according to certain strata. But to be honest, from the life of a single cell to formation of complex organisms, food is not something very easy to get. They have to struggle to get that food and energy. So that is why it is a natural tendency of any living cell to conserve energy rather than spending energy. And that is the reason why we have this obesity pandemic right now in the world, because of too much energy that is available, and our cells are naturally prone to conserve energy. We tend to develop obesity if we eat too much. And there are certain individuals, especially who are prone for this prenatal undernutrition. The fact that during embryonic and this fetal life itself, if they are exposed to this undernutrition, their cells will be more programmed towards conserving energy. Once they are born and the situation reverses, and they are going to develop the complications like PCOS and hyperinsulinemia. So why hyperinsulinemia? Because we know that insulin is an energy conserving hormone, it's an anabolic hormone, and that is the reason why the body is programmed to produce this hyperinsulinemia. And at the same time, why ovarian dysfunction? Because ovulation is something that is associated with energy, and when you want to conserve energy, you have to avoid wasting of resources in the form of ovulation, steroidogenesis. Yes, that's not needed. So that is the reason probably why undernutrition is associated with ovarian dysfunction as well. So this is an interesting hypothesis, and there are a lot of accumulating evidences for the same. And let us go and understand how hyperinsulinemia is associated with development of hyperandrogenism. This is a very important pathophysiology because this gives a lot of ideas with regards to the treatment as well. So pay proper attention to this. Remember, this hyperinsulinemia can be due to obesity and insulin resistance itself. So remember, in the world, the most common cause of insulin resistance is obesity. Obesity is the most common cause of insulin resistance, even though there are some rarer causes like antibody-related insulin resistance, but we don't want to confuse with those facts. Most common reason for developing this insulin resistance is obesity. And how obesity can produce insulin resistance, this theory is what we refer to as the overspill hypothesis, where naturally, when somebody takes more food, which means somebody takes more fat and more calories and more food, this fat generally tries to be stored first in the cutaneous adipocytes. That's really important. First, they go to the cutaneous adipocytes as storage. And once the cutaneous adipocytes are exceeded from their capacity, which means they spill over, and this spillover of fat generally goes towards the liver, where it is stored, and to the muscle, where it is stored. And this spilling over of fat and its storage in the liver and the muscle is the key to develop this insulin resistance, because this fat that is present in the liver and the muscle is the reason for developing this insulin resistance in the first place. And how this fat is linked to insulin resistance is a matter of different topic. We will be discussing that in diabetes mellitus chapter, but understand that this fat is the reason for developing this insulin resistance in the first place. And remember how much of this cutaneous adipocytes are there, the number and their capacity, and at the same time how much fat you can store underneath the skin determines your development of insulin resistance as well. That is the reason why your peripheral obesity is not associated with insulin resistance, but your central obesity is more in favor of insulin resistance, because the more you store the fat under the cutaneous regions, it's okay. So you don't develop insulin resistance unless and until it spills over to the liver and the muscle. Clear? So anyways, so whenever you develop insulin resistance, you are going to develop excess insulin release, because obviously to overcome resistance, somebody gives you resistance, you try to push harder, but in this case you are going to produce more insulin and try to push harder and overcome that resistance. So that is the reason why you develop hyperinsulinemia. Clear? But obesity and insulin resistance are like a compounding factor, but remember these PCOS people are naturally prone to develop hyperinsulinemia by default, and obesity and insulin resistance are just like this confounding factors for this hyperinsulinemia development. And how come a hyperinsulinemia can produce hyperandrogenism? For this, you have to understand the effects of excess insulin on multiple tissues. So this excess insulin is going to act on the ovaries, and this is supposed to be the most important mechanism. They are going to act on ovaries, and they are going to act on the adrenal glands, and they are going to act on hypothalamus, and they are going to act on the adipocytes. I've told you this mechanism already. Adipocytes, and they are also going to act on the liver as well. So all these have been proven research-wise, and molecular bases are clearly known regarding all these things. So there is no controversies or questions regarding this. How they act on the ovary and what they do in the ovary. This excessive insulin is known to stimulate the theca cells, and these theca cells are well known to produce excessive androgens. Clear? And this hyperinsulinemia is known to make the theca cells more sensitive to LH, and at the same time they increase the size of the theca cells as well, which is clearly proven experimentally, and that is the reason why this insulin stimulates the ovaries to produce more androgens, and this is considered to be the most important mechanism of all. And adrenals are a little controversial, but still the insulin is supposed to stimulate the zona reticularis and 17-hydroxylase enzyme to produce more androgens, and slightly controversial, but still this forms a minor mechanism as far as this PCOS is concerned. And hypothalamus as well. It's going to alter the nature of the pulses in the hypothalamus. What pulses? The nature of the GnRH pulses in the hypothalamus in such a way that they are going to produce excessive luteinizing hormone. So because they produce excessive luteinizing hormone, which is going to act on the theca cells, and they are going to produce excessive androgens. Remember, this evidence comes from the fact that this increased LH is seen in approximately 50 to 70% of PCOS patients, if not all the patients of PCOS, but approximately 50 to 70% of PCOS patients will have elevated LH. So whether this elevated LH is a cause or an effect, we don't understand clearly, but still this elevated LH is not seen in all the patients, but this ovarian dysfunction is seen in almost all the patients, and that is the reason why PCOS is an ovarian cause of hyperandrogenism. Once again, I'm substantiating that fact. And adipocytes, we know insulin is going to stimulate these adipocytes, and they're going to stimulate the activity of 17-beta-HSD in the adipocytes, which is generally going to produce more androgens, and in fact more potent androgens like testosterone. And the effect of insulin on the liver is multifold. For that matters, the first effect is they are going to reduce the IGF-1 binding protein, that is called IGF-1BP or IGF-BP1, which means the ability of the liver to saturate this IGF-1 will reduce because the binding protein is less, which will lead to increased amounts of IGF-1. And this IGF-1 is an insulin-like growth factor. We have already discussed in the growth hormone chapter where IGF-1 acts like insulin in majority of the situations, where especially the anabolic effects is going to be like insulin, and they are going to stimulate the theca cells like insulin, which is going to produce more androgens. It's been clearly proven, all these things, that IGF-1 is a stimulating agent for theca cells. And liver also responds to insulin by producing reduced amounts of sex hormone binding globulin. This reduced amounts of sex hormone binding globulin production is again very important because they are going to produce more free androgens, free testosterone. Because SHBG is one of the major binding proteins for testosterone, and if the SHBG levels are low, they are going to produce more free androgens. And this also explains the breast atrophy that happens in females with cirrhosis, because in cirrhosis, low production of SHBG will result in more free androgens in a female, and that's going to be the reason for the breast atrophy that you see in the female individuals with cirrhosis. And at the same time, this also the rationale for giving oral contraceptive pills in PCOS. OCPs act by multiple mechanisms. One of the important mechanisms is by increasing the SHBG. We know the fact that estrogens are going to increase the binding globulins. May it be the TBG, thyroid binding globulin, may it be the sex hormone binding globulin. So estrogens are known to increase them. So estrogen, by increasing the sex hormone binding globulin, they are going to reduce the amount of free androgens, and thus reducing hyperandrogenism to an extent in ladies with PCOS. And that is the rationale of giving, one of the rationales of giving this estrogen progesterone pills as well in patients with PCOS. So these are the mechanisms how hyperinsulinemia can produce hyperandrogenism. And once you have developed this hyperandrogenism due to any reason, so the effect is going to compound itself And this excessive androgens will try to sustain the hyperandrogenism in the body through multiple mechanisms. How they try to sustain themselves? Let us see. Remember, these excessive androgens are known to reduce the binding globulins. Clear? So which means insulin will reduce the SHBG, which produces more free androgens. This excessive androgens itself will act by a vicious mechanism, and they reduce more and more SHBG production, which means estrogens will increase the binding globulins, whereas androgens are known to reduce the binding globulins, which is very clearly proven. Even TBG reduces with androgens. Similarly, SHBG also will reduce with excessive androgens, which generally tend to produce more and more free androgens. So it's like a vicious cycle. Clear? So that's one mechanism. And the second mechanism is the fact that this excessive androgens have an effect on the ovary also. In the ovary, we have different types of follicles. So let us assume a small follicle and you have a large follicle. Remember the fact this excessive androgens likely to stimulate the ovary to go towards more of small follicle production, and they selectively inhibit the large follicle formation. And this effect is clearly proven experimentally again, where the androgens stimulate the sustenance of small follicles rather than production of a large follicle, which means your dominant follicle never emerges with hyperandrogenism. Once the dominant follicle does not emerge in hyperandrogenism, you develop anovulation, which means the dominant follicle is the one that is to be ovulated. And if that doesn't happen, if the dominant follicle emergence doesn't happen, you generally go for anovulation. And when you stimulate the small follicles and maintain that small follicles, so there will be accumulation of these small follicles. And this has multifold importance. And this accumulation of small follicles is the main reason for developing this polycystic ovary appearance in ultrasound, number one. And at the same time, the small follicles have reduced amount of FSH receptors and they have more LH receptors. We have studied that already in the female reproductive physiology. That is why that video is really important. So they have less FSH receptors at that point and they have more LH receptors, which means because of the reduced FSH receptor and more LH receptors, they generally tend to produce more androgens as well. They generally tend to produce more androgens. Clear? So which means they cannot produce a lot of estrogens. Instead, they tend to produce more and more androgens with regards to estrogen. Clear? This excessive androgens itself has effect on the hypothalamus itself. Hypothalamus and the pituitary. We know the hypothalamic and pituitary axis. So what these androgens are going to do? Remember, this pituitary is going to produce this two hormones, that is FSH and LH. So depending on the pulse amplitude, you have LH and you have FSH. Usually the production of FSH and LH is dependent on the GnRH pulses. So hypothalamus gives this GnRH pulses. Usually faster pulses of GnRH will result in LH production and slower pulses of GnRH will result in FSH production. This fact we know that already. So now this LH and FSH are going to act on the ovaries and they are going to produce estrogens and progesterone respectively. Remember, FSH in response they are going to produce estrogen and LH in response they produce androgen. The theca cells are going to respond to LH and the granulosa cells are going to respond to FSH and they are going to produce estrogens. But remember, in patients who are having hyperandrogenism, there will be one important mechanism that will be disrupted. And before that, let me tell you what is the main feedback for the FSH. Remember, the major feedback for the FSH is the inhibin B. A little comes from estrogen as well, but majority of the feedback to the negative feedback to the FSH comes from the inhibin B. Similarly, majority of the negative feedback to the LH production will come from the progesterone. Clear? So what these androgens do? So if they produce excessive androgens, this excessive androgens will actually disrupt the feedback that is given by progesterone to produce LH, which means progesterone tend to inhibit the faster pulses of GnRH at the hypothalamic level itself. But this disruption of the feedback mechanism that is done by the excessive androgens will result in this progesterone becoming unable to give feedback to the hypothalamus as well as the pituitary, which means there will be more production of LH. This more production of LH means you are going to stimulate the theca cells more. Already the ovary is dysfunctional here. That is going to result in more and more production of androgens, which means this hyperandrogenism is going to sustain itself by producing more and more hyperandrogenism. And at the same time, this anovulation is also one of the key factors for producing hyperandrogenism, more and more hyperandrogenism, because when you get an anovulation, because ovulation means your dominant follicle will convert to a corpus luteum. This luteum, one of the important principles behind this formation of the luteum is to produce progesterone during the luteal phase. Clear? So if you don't have ovulation, which means you cannot produce the luteal phase and the patient will not have progesterone in their blood. So if you do not have progesterone, I told you progesterone is the most important feedback for LH, right? So when you have lesser and lesser amounts of progesterone due to anovulation, so obviously are going to result in more and more production of LH, which is going to in turn produce more and more production of androgens, and this is multi-modal mechanism, and you have a lot of things that where androgens try to sustain the hyperandrogenism by variety of principles and mechanisms, and this is very, very important to understand. I've told you different mechanisms where this hyperandrogenism tries to sustain itself. Clear? So that is the reason why majority of the patients with PCOS will have elevated LH along with hyperandrogenism, and they have a normal amount of FSH most of the time. So FSH is not something that is altered in a patient with a PCOS. They have normal amount of FSH. And it's also worth noting that these patients doesn't only have elevated androgens, these patients also tend to have more estrogens. You might argue, how come these patients generally tend to have high estrogens, and what is the mechanism behind that? There are two mechanisms happen in PCOS patients behind this hyperestrogenism. First is the obesity. I told you this adipocytes are rich in aromatase, right? Which also tells the fact that whenever you have more androgens, this adipocytes can convert this androgens to estrogens, which means because of the obesity itself, they can produce more estrogens. And at the same time, your granulosa cells. So obviously, if there are more androgens, the substrate is more. Even though the granulosa cells, respond to FSH, fine. Here the FSH is normal, but if the substrate flow is more, if the androgens are more in their body, so because of the excessive androgens, sheerly because of the excessive androgens, these excessive androgens by the granulosa cell, which do contain this aromatase enzyme, can be converted to excessive estrogens. So which means PCOS is a condition of not only hyperandrogenism, they do have excessive estrogens in the blood as well. So what is the evidence that these patients are having excessive estrogen? And this also explains a lot of things in PCOS. So this is also the reason why these patients with PCOS generally tend to have thickened endometrium, number one. And coupled with anovulatory cycles, they develop bleeding often, resulting in oligomenorrhea or amenorrhea. But once they get bleeding, and because of the continuous action of estrogen for a longer period of time, they can go for menorrhagia as well. They get less cycles, but if they do get cycles, they go for a lot of blood, because these high estrogens are going to continuously stimulate this uterus for a long time, and the endometrium will keep thickening because estrogen is a proliferative hormone, so it's going to keep stimulating the endometrium to thicken more and more and more, and finally, ultimately, once they develop bleeding, all this will be shed and resulting in severe bleeding, menorrhagia. And that is why PCOS is a condition that is related with oligomenorrhea, amenorrhea, as well as menorrhagia. You have to be very clear about that. And that is due to anovulation coupled with high estrogen. Fine. So, and that is also one of the main reasons why if you take the complication list in PCOS, it would have been clearly mentioned that these patients are prone for endometrial and breast cancer. Why endometrial and breast cancer? That is because of hyperestrogenism and estrogen that is continuously acting for a long time, coupled with anovulation where there is no progesterone to produce bleeding, because progesterone withdrawal, action of progesterone followed by progesterone withdrawal is the main reason for menstrual bleeding. So if there is anovulation, no progesterone priming of the endometrium, no progesterone withdrawal if there is no progesterone already, so they won't get bleeding. That's why anovulation is associated with amenorrhea. But continuously through all this time, even during this periods where they don't develop this menstrual cycle, but estrogen is continuously acting on the uterus to produce a thickened endometrium, causing severe bleeding if they get bleeding once in 3 or 4 months. So prone for endometrial as well as breast cancer. That is because of excessive estrogens in these girls. Clear? So this is again a very important point to understand. They don't only have excessive androgens, they do have excessive estrogens also with them. Fine. So what are the things you will see in PCOS in a nutshell? So let us see the features and what are the biochemical as well as some of the important points that you have collected till now. So you are going to have excessive LH. Unfortunately, this is seen only in 50 to 70% of the patients, and normal FSH. That also gives rise to the rationale of that famous LH-FSH ratio of more than 3:1. This is not universally true, but seen in most of the patients. They generally tend to have more testosterone and reduced sex hormone binding globulin. We know this mechanism already. They generally tend to have more insulin because they have hyperinsulinemia, and because of the same, they develop glucose intolerance as well. Glucose intolerance as well. And apart from that, ovaries on ultrasound look a bit polycystic. And the definition of polycystic ovaries is different with different guidelines, but the universal consensus agreed is the fact that there should be at least more than or equal to 12 follicles and with a net ovarian volume of more than 10 ml. So why the ovarian volume is increased here? There are multiple reasons. Because of the accumulation of small follicles producing cysts, the ovaries tend to enlarge. At the same time, this LH stimulating the theca cells, and you know that the theca cells are inherently hyperactive, and insulin as well as LH that is high in these girls and ladies is going to stimulate the theca cells to go for hyperplasia and hypertrophy, and that is also one of the main reasons why these ovaries can be enlarged. So that's why the ovarian volume should be more than 10 ml with at least 12 follicles or more. And each follicle, this is a very important criteria, each follicle should be in the range of 2 to 9 millimeter, which means we are talking about selective small follicle proliferation, not the dominant follicle, because dominant follicles we know they are 1.5 to 1.8 centimeters, that is 15 to 18 millimeter. This criteria tells you the fact that you don't see the dominant follicle. Instead, what the cysts, what all you see are the collection of small follicles and not the dominant follicle. So that's why all these criteria are very, very important as far as diagnosing this polycystic ovarian syndrome in the ultrasound is concerned. Clear? So these are the features that you generally see, but remember what is PCOS in a nutshell. So how can you describe a PCOS? You have told all the biochemical profile, but what is PCOS? PCOS, you have a beautiful definition. To be honest, I like this definition the most. It's an unexplained hyperandrogenism. Point number 1, unexplained hyperandrogenism, which means you have to rule out other cause of hyperandrogenism. It's a idiopathic cause of hyperandrogenism. You have to rule out other secondary cause of hyperandrogenism before concretely diagnosing a PCOS, and it's of ovarian origin. I clearly told you from the beginning that it's an ovarian hyperandrogenism and not a adrenal or a other cause of hyperandrogenism, peripheral hyperandrogenism. It's an ovarian hyperandrogenism, ovarian origin, and it should be persisting for at least 2 years. I mean, this definition, I'll tell you what is the importance of that persisting for 2 years or more, because especially this is true in adolescent girls who have just achieved puberty, because there is something called a pubertal hyperandrogenism, which is quite relatively common, which tends to settle within a period of 1 to 2 years. And that is the reason why this definition was given, especially for this adolescent girls or very early age where they develop PCOS. So persisting for at least 2 years. This is such a beautiful definition. It's an unexplained hyperandrogenism with which is predominantly ovarian in nature and persisting for at least 2 years or more. Having described the PCOS, let us go on to see the criteria that has been given to diagnose PCOS. Criteria is based on 3 important things. One is the hyperandrogenism, and second is the anovulation, and third one is the polycystic ovary appearance in ultrasound. So I can write hyperandrogenism, which can be either clinical or it can be biochemical. And second one is the anovulation, which can manifest as amenorrhea. PCOS can produce both primary as well as secondary amenorrhea, even though secondary is relatively more common, and they can produce oligomenorrhea and they can produce amenorrhea as well. and menorrhagia. So we know the mechanisms of how PCOS does produce menorrhagia and anovulation in general, how it produces menorrhagia. We have seen already the mechanisms behind that. And the third one is the polycystic ovary appearance on ultrasound. According to many endocrinologists and according to me as well, this polycystic ovary is the least important of all. This is not at all important because polycystic ovaries are often the effect of the disease and hyperandrogenism rather than the cause of the disease. Many students do think that this is the reason for development of the syndrome that we have seen. In fact, the name of the syndrome itself, I feel it's a misnomer, the polycystic ovarian syndrome, where it tells that polycystic ovaries are the reason for the disease that you're seeing. No, it's not. Polycystic ovaries are just the effect of underlying disease that is unexplained hyperandrogenism, and it is not the real reason for the disease that you're seeing clinically. And PCOS, because of that, PCOS is divided into many different types based on hyperandrogenism, polycystic ovaries, and anovulation. You have 4 different types of PCOS. So first we have the PCOS type 1, which tells you should have all 3 things, that is hyperandrogenism, anovulation, and polycystic ovaries. And you have a PCOS type 2, where you tend to have a hyperandrogenism and anovulation, but you don't have polycystic ovaries. And you have third type of PCOS, where you have hyperandrogenism and polycystic ovaries, but you don't have a anovulation. And the fourth controversial type of PCOS, where many endocrinologists do not agree this as a PCOS, where you don't have hyperandrogenism and you have a anovulation and polycystic ovaries. That's a very controversial type of PCOS, to be honest. And these are the basis of formation of this criteria for PCOS. What are the criteria? The first one is the classic PCOS criteria, which was given initially, which tells you that you should have all these 3 things to tell it's a PCOS, that hyperandrogenism, anovulation, and polycystic ovaries. And the second one is the NIH criteria, National Institute of Health NIH criteria, where it told like you should have this hyperandrogenism and anovulation to diagnose as PCOS, but polycystic ovaries are optional. Even if you don't have polycystic ovaries, it's okay. If you have hyperandrogenism and anovulation, you can diagnose PCOS. And the third one is the Androgen Excess Society. This is what many endocrinologists follow, androgen excess society criteria, where it clearly tells hyperandrogenism is a must to diagnose PCOS, where anovulation and polycystic ovaries, out of 2, if you have any one, it's enough, but hyperandrogenism is a must to diagnose PCOS, that is androgen excess society criteria. And next one, you have the most liberal Rotterdam criteria, where many gynecologists are oriented towards, which tells you it's very liberal. Like they tell you it's okay, we agree with PCOS even if you do not have hyperandrogenism. It's just if you have this other 2, anovulation and polycystic ovaries, it's okay that we can call it as PCOS. So Rotterdam criteria tells just if you have any 2 or the 3 among the 3 features which I've told you, that is hyperandrogenism, anovulation, and polycystic ovaries, you can have PCOS. That is according to the Rotterdam criteria. But most of the endocrinologists, including me, believe in androgen excess society criteria, where hyperandrogenism is a must. Without hyperandrogenism, just the presence of polycystic ovaries will not tell that the patient is having PCOS. So these are the criteria, and remember, criteria are just to guide you. There are multiple criteria. There are more than 10-15 criteria across the world by different societies, but criteria are not important. As far as I'm concerned, in any disease in medicine, it's always about the understanding of the disease that gives you the idea. Because as a beginner, it's always an inherent tendency to orient towards most of the criteria and mugging up those criteria and following that very strictly. You can be liberal with those criteria if your personal expertise is too much, and if your personal expertise is way ahead of all these things, then you can give relaxation to this criteria and you can consider more of the patient approach rather than the criteria-based approach. I always give the patient-based approach rather than the criteria-based approach. Criteria are only to help you, to guide you, to orient towards a particular disease, but not to completely stick upon and just be a criteria man. Don't be that. So anyway, so let us move on to the clinical and biochemical hyperandrogenism. How will you define a clinical and biochemical hyperandrogenism? So remember, hyperandrogenism is different from something called a virilism. So both are different ones. So first, what do you mean by this hyperandrogenism? What excessive androgens in a female can do? And before telling about that virilism in a adult female, we have already studied that virilism in a fetus means, virilization in a fetus means that labioscrotal fusion. But please do understand the fact this virilization and labioscrotal fusion happens in fetus only at 8 to 13 weeks of time. So once you cross that 13 weeks of fetal life, you cannot produce that labioskrotal fusion how much ever androgens you supply to the female fetus. They will only result in clitoromegaly. This is very, very important point, which means after the 13 weeks of fetal life, especially in the adult life, once the child is born, even if you expose them to how much ever androgens you want, they will produce only clitoromegaly. They will not produce labioskrotal fusion, which means labioskrotal fusion is impossible in adult life. In fact, it's impossible after the 13 weeks of fetal life itself. It's not possible. So that's something you have to understand. So clinically, how will you diagnose hyperandrogenism? Based on the effect on the pilosebaceous unit. Pilosebaceous unit, this is the most important and the most significant effect of excessive androgens. So first is on the hair and second is on the acne. So acne is very common in girls with a little bit of excessive androgens. Remember, puberty time, girls do generally develop very increased number of acne, because puberty itself is a cause of hyperandrogenism, called as a pubertal hyperandrogenism, which generally tends to resolve. In any girl with persistent acne or very severe acne, after 1 or 2 years of puberty, has to be evaluated for hyperandrogenism. I mean, for evaluation of PCOS and other cause of hyperandrogenism, because that could be a sign of underlying problem which is causing that hyperandrogenism, not just a simple physiological pubertal hyperandrogenism. But acne is a very common thing. Even males do experience at puberty because of the androgens. But androgen is known to cause the sebum to be very thick and viscous. So that is the reason why that plugs up and start developing this acne during the pubertal life. Fine. So what are the effects on the hair? So that's very important. Remember, there are two types of hair we know. There is vellus hair and you have a terminal hair. So what do you mean by a vellus hair? This vellus hair is more of very fine and thin hair, which is typically depigmented and more whitish, and seen in the extremities. Very often in the extremities, and sometimes in the this area near the ears, you see this small fine hair that is called a vellus hair. And what do you mean by this terminal hair? This terminal hair is more coarse and dark. It's thicker. So like what you see in the pubic and axillary areas and what you see in the head. So these are terminal hair. So what these excessive androgens do? Remember, androgens act on areas that are sexually dependent. So there are areas of hair which are sexually dependent, areas of skin which are sexually dependent. And in the sexually dependent areas, they can transform this vellus hair to terminal hair. And in certain sexually dependent regions, they can transform this terminal hair to vellus hair. So both can happen. So how they can transform this vellus hair into a terminal hair? Remember, in certain sexually dependent areas like your beard area, your mustache area, that means in the face, and in your chest, especially around the nipples, in the middle of the chest, and in pubic regions, especially in the thighs, back, abdomen, buttocks, gluteal region. So these are the areas where your androgens these are sexually dependent areas, and these areas your excessive androgens can transform the vellus hair to terminal hair, which means these areas will have new hair growth and they look more darker and it look like a beard and the mustache. And there are some areas where testosterone and excessive androgens can convert this terminal hair into vellus hair, especially in the anterolateral frontal area. That's the reason for this anterolateral hair recession, or this is also referred to as male pattern hair recession, or frontal hair recession, which is quite common in males. That is due to high levels of testosterone circulating in them. But anyways, so these are the effects of androgens that you can expect in a female. So at extremely high levels, they can produce frontal hair recession. At moderately high levels, like in PCOS, they can produce this hirsutism by converting this vellus hair in the sexually dependent areas to terminal hair. So that is very important. So there are two things I told you. One is the hirsutism, and second thing, they can also result in frontal hair recession at little bit higher levels. Also note the fact that this testosterone is one of the main players in producing this hydradenitis suppurativa. It doesn't develop in all the individuals, but certain prone individuals develop this hydradenitis suppurativa as well. Not all, but few they can develop this hydradenitis suppurativa. But what are the virilism? What do you mean by virilism, and what very high levels of androgens can do. Extremely high levels of androgens can produce clytromegaly, but they cannot produce labioskrotal fusion in adults. So clytromegaly, they can produce voice changes where the voice will become more of a male-like with a low pitch, more bass, their voice changes will happen, and they can produce muscle hypertrophy and muscle changes which is very similar to that of a male. Clear? So these are the clinical effects of hyperandrogenism and virilism, but in general PCOS will restrict itself to hyperandrogenism. If you develop a virilism, do not diagnose a PCOS. PCOS is not a condition that produces virilism at all. But what are the biochemical levels that will tell you whether it's a hyperandrogenism or a virilism? Remember, if the total testosterone levels, we are going to do total testosterone, if it's more than 55 nanograms per deciliter, remember the normal total testosterone levels are somewhere around 8 to 48 with my wild guess, 8 to 48 nanograms per deciliter. So if it's more than 55 nanograms per deciliter, we call it as a hyperandrogenic testosterone. Or if you want to tell in nanomoles, according to your Western guidelines, in your European textbooks, they would have given more than 3.1 nanomoles per liter as elevated testosterone. Similarly, the virile levels are where your testosterone, total testosterone levels are more than 190 nanograms per deciliter, even though this is quite variable, which tells you like more than 200, but European textbooks give, which is equivalent to 5.1 or more nanomoles per deciliter is a virile level of total testosterone. Whenever you see this virile levels of testosterone, it is unlikely to have a PCOS. Patient is unlikely to be suffering from PCOS. You have to obviously evaluate for a androgen secreting tumor, which can be present either in the ovary or in the adrenal glands. So with regards to the testosterone assays, testosterone can be evaluated in the form of total testosterone or a free testosterone, even though we generally perform this total testosterone only. But one small disadvantage with total testosterone is the fact that it is going to test both bound as well as free hormones, which means there are conditions which can produce falsely elevated total testosterone, and there are conditions which can produce falsely lower total testosterone. In the fact that conditions that increase the sex hormone binding globulin will produce falsely elevated total testosterone, and condition that reduces the sex hormone binding globulin, like exposure to your different types of drugs and probably liver disease, nephrotic syndrome. The best examples of liver disease which produces reduced testosterone, reduced sex hormone binding globulin because the liver is dysfunctional, and nephrotic syndrome where you will be losing this SHBG in the urine because of the proteinuria. So in these conditions, you might have a falsely lower amount of SHBG. There are certain conditions that increase SHBG, like for example, your estrogen itself can increase the SHBG, that can show falsely elevated testosterone, and your steroids like prednisolone can increase the SHBG, which can produce falsely elevated levels of testosterone. Clear? So there are some conditions which can produce this falsely elevated total testosterone because of their effects on SHBG, but free testosterone is more accurate, but the problem is this increased accuracy and sensitivity comes at excessive cost. That is the reason why majority of the guidelines do not do free testosterone. They generally stick on to the total testosterone, to be honest. Clear? So how they measure this free testosterone? It's the same principle that we see, that we had discussed on the free thyroxine, like how would you find out? So the most efficient way is the equilibrium dialysis. This is not available in many centers, even tertiary centers, but this is the most accurate. Or you can use sex hormone binding globulin based assays also. For example, in your free T4 assays, you used something called the T3 resin uptake index, isn't it? So based on that, and you use this, TBG related calculations, and you found out the free T4. Similarly, SHBG based assays are also there, which is far less accurate compared to the equilibrium dialysis, but still the most commonly performed technique in Indian subcontinent is the SHBG based assays, which is much less costly compared to the equilibrium dialysis. Clear? So there are two types of testosterone that you can do. When you will take a testosterone, basically, especially when you take a total testosterone, it's better to do at 8 AM fasting testosterone, and it's better to do around day 2 to day 10 of menstrual cycle. So around day 2 to day 10, this is the best time to do a total testosterone assay. I generally do a day 5 or day 6, that's the midpoint, that's what I do, but in general guidelines tell you can do around day 2 to day 10, that's the place where you can do a total testosterone. Remember, when the patient is having clinical hyperandrogenism, but a normal level of total testosterone, So this is the place where you will do a free testosterone usually. So apart from that, we don't do a free testosterone. If the patient is having clinical hyperandrogenism, if the total testosterone levels are elevated, there itself it's proven that you don't need to do a free testosterone in that case. It's just okay. If you have a clinical hyperandrogenism, but the total testosterone levels are not agreeing with your clinical profile, so then you can do a free testosterone to confirm whether it's really a elevated testosterone or not, or elevated androgens in the patient is there or not. So these are some of the things that you have to note about the hyperandrogenism perspective. Then we will move on to the definitions of anovulation. Remember, anovulation can manifest as amenorrhea, anovulation can manifest as oligomenorrhea, anovulation can manifest as a menorrhagia as well. So first, you have to know PCOS can manifest as a primary as well as secondary amenorrhea, even though secondary amenorrhea is far more common compared to primary amenorrhea. And what is the definition of primary amenorrhea? Primary amenorrhea means the patient has not experienced any cycle till 15 years of age, which means even after 15th birthday, 15 years of completion, the patient has not experienced cycles at all. That's a primary amenorrhea. Or if the patient has not got any cycles after 3 years of development of secondary sexual characters, which means the most important secondary sexual character as far as females are concerned is the breast development. Even after 3 years of breast development or development of secondary sexual characters, if the patient has not got any cycles, that is what we define as a primary amenorrhea. So what do you mean by secondary amenorrhea? Secondary amenorrhea means if you have amenorrhea for more than 3 months or 90 days in a girl who has previously had a spontaneous menstrual cycle. Already the girl has developed a spontaneous menstrual cycle, but after that, in between any part of life, before achieving menopause, 3 months, if they do not have experienced cycles at all, that's what we refer to as a secondary amenorrhea. Clear? But the girl should have experienced spontaneous menstrual cycle already in her life. So what do you mean by menorrhagia? Menorrhagia means your cycle length is less than 21 days, or if your cycle is lasting duration, cycle duration, that a single cycle lasts for more than 7 days. Cycle length is less than 21 days or cycle duration is more than a week. This is what we define as a menorrhagia. And what do you mean by oligomenorrhea? Oligomenorrhea is, has to be defined based on the age of the child and especially after the pubertal life. For example, if it's the first year post-puberty, which means after pubertal life, once they have achieved puberty in the first year post-puberty, it is defined as less than 4 cycles per year, because immediately after puberty, they generally tend to experience lesser cycles because that is the time they are going for gynecological and sexual maturity. They don't experience that much cycles. So in the first year of post-pubertal life, if it's less than 4 cycles per year, or in the second year of post-pubertal life, if it's less than 6 cycles per year, or if in the second to 5th year of post-pubertal life, if it is less than 8 cycles per year, or if it's after 5 years of post-pubertal life, if it is less than 9 cycles per year. Remember, this 5 years of post-pubertal life is the definition of gynecological maturity as well. Once the girl has experienced puberty, that cutoff of 5 years, after puberty, that 5 years cutoff is the cutoff where you tell the girl has achieved gynecological and sexual maturity. Clear? So after 5 years, if it is less than 9 years, which means the girl has achieved gynecological maturity. After that, if you have less than 9 cycles per year, this is what we define as a oligomenorrhea. Remember, this oligomenorrhea definition should be based on the age. There is also a need to objectify this hirsutism and this acne, because there is considerable subjective definitions of hirsutism and acne, but some doctors may think this is hirsutism and some may not think that is hirsutism. So to objectify that, we have a very important scoring system called as Ferryman-Gallwey scoring. So this is to objectify and to make this hirsutism diagnosis as a universal entity. This is called Ferryman and Gallwey scoring. So it's called FGS. Clear? So based on the Ferryman-Gallwey scoring, you can call, if the scores are less than 8, as mild hirsutism. If the scores are 18 to 15, you call it as moderate hirsutism. And if the scores are more than 15, you call it as severe hirsutism. Remember, any patient with severe hirsutism, there is 84% probability that the patient is having hyperandrogenism, which means whenever the patient is having severe FGS score that is more than 15, it's almost sure that the patient will be suffering from hyperandrogenism. That is also the basis why we do total testosterone most importantly for this moderate patients, because less than 8, extremely low probability of hyperandrogenism. So here the total testosterone values will be usually useless, because even if it is elevated, we think of falsely elevated total testosterone. You have to think about other causes, but because there is a low probability of hyperandrogenism. Remember, whenever you have a extreme elevation of FGS score of more than 15 means 84%, which means it's very high, which means invariably the total testosterone levels will be elevated in this case. So why you want to do a total testosterone? But still we do a total testosterone here just to confirm this hyperandrogenism. In this case, if you see a normal total testosterone, this is the place where you have to do a free testosterone, to be honest, to confirm the hyperandrogenism, because here the normal testosterone I will be taking as usually a falsely low range, because FGS more than 15 is almost a sure sign of existing clinical hyperandrogenism. So anyway, we are going to treat that. So why you want to do a total testosterone? Doing a total testosterone is just to confirm the existence of hyperandrogenism. So these are the patients where they have intermediate probability for having hyperandrogenism. So that is the reason why the total testosterone values are best to be done in this FGS score of 8 to 15. Clear? So this is the place where your androgen levels or the total testosterone levels are going to give you the best idea regarding the underlying hyperandrogenism. So in general, I can tell it in a nutshell that whenever the FGS scores are more than 8, and this is the place where we are going to do a total testosterone, not for FGS scores less than 8. In a nutshell, what are the areas to be assessed? As I told you before, the beard areas, the mustache areas, then the chest areas, the abdominal areas, the trunk areas, especially in the shoulders and in the thighs, in the back, in the buttocks, gluteal region. These are the areas will be assessed, and depending on the amount of hair distribution, it is given a score of 1, 2, 3 and 4, and we can clearly objectify the hirsutism as well. And it's also worth mentioning that this score is subjected to multiple racial differences. In general, usually your Asians and Chinese people generally tend to have lesser hirsutism racially itself. Lesser scores, according to FGS score, they will have a lesser scores basically itself. So again, there is considerable confusion what should be called as hirsutism. So these races generally tend to have lower rates of hirsutism, lower amount of hair distribution in their body. Compared to the Mediterranean people generally tend to have higher levels of hirsutism, higher FGS score in comparison normally, even without hyperandrogenism. So this brings to a small question that really it should be adjusted according to the race or not. Yes, it has to be. But anyway, right now it's not yet done clearly. But there are some other new scores that are coming that can adjust according to the race. But still, the traditional gold standard is the Ferryman and Galloway scoring. So among the Indians itself, there are considerable racial differences are there, because Indians are something like a unity in diversity. You have a lot of races mixed in the Indian population and Indian subcontinent. So among the Indians itself, there are certain ethnic groups which have a little bit more incidence of hirsutism, and even with the normal androgen, and relatively more hair distribution compared to the other races like Punjabis, Sindhis, Bengalis and Keralites. So these are the group of girls who tend to have a relatively more FGS score with the normal androgen itself. So this has to be considered a little bit, but still for your exams, just understand about the Ferryman and Galloway scoring. Similarly, you can even quantify the acne also to an extent, but even though it's not that great correlation with hyperandrogenism, still you can consider acne severity as well. So first of all, there are two things which you should consider as far as acne is concerned. One is the comedones and second is the inflammatory lesions. There are two inflammatory lesions, one is the papule and second is a pustule. What is the definition? What is the criteria to put them under acne? First of all, they should have a comedone for sure. Comedone is defined as more than 1 millimeter in size, and papules are the ones which have less than 5 millimeter size, and pustules are the ones which should have at least more than 5 millimeter in size. These are inflammatory lesions, and to tell it is a mild acne, the comedone should be less than 10 and inflammatory lesion should be less than 10. Moderate should have comedones and inflammatory lesions in the range of 25, and severe falls in a category where the comedones and inflammatory lesions are more than 25. So these are the things that you have to consider before making this objectified, and this is the criteria for mild, moderate and severe acne. Whenever the patient is suffering from a moderate to severe acne, it suggests that there is 25% probability. It is not very good, but still it suggests that there is a 25% probability that the patient is having hyperandrogenism. So that is why all cases of moderate to severe acne alone will not be evaluated for hyperandrogenism, but instead any patient with moderate to severe acne, which is either persistent, not responding to your therapy, or whichever necessitates the use of retinoids, because when you use retinoids means it's a severe acne. So whichever acne that necessitates the use of retinoids, or whichever acne that is moderate to severe but persistent, not responding to your conventional treatment, has to be evaluated for hyperandrogenism. Clear? So this is how you evaluate a hyperandrogenism and objectify the hyperandrogenism in females. Then what are the differential diagnoses for PCOS? This differential diagnosis I am telling because you have to know the etiologies of hyperandrogenism, because we know that PCOS is equal to unexplained hyperandrogenism, which means you should not be able to explain that hyperandrogenism, which also comes to a conclusion that you have to rule out definitely other causes of hyperandrogenism. So what are the miscellaneous causes or other causes of hyperandrogenism? I can divide into physiological hyperandrogenism and probably a pathological hyperandrogenism. Physiological hyperandrogenism comes due to two reasons. One could be a pregnancy-related hyperandrogenism, or it could be a pubertal hyperandrogenism. Remember, during pregnancy, hyperandrogenism is a common feature, especially in the late third trimester and probably in the early first trimester, because where the beta-HCG surge will be there in the early first trimester, which acts on the LH receptors, because there is a common receptor called LHCG receptor, where beta cell will act on the LH receptor in the corpus luteum, and they can produce sustenance of the corpus luteum. At the same time, they can stimulate the theca cells to produce relatively more amount of androgens. So remember, virilization during pregnancy is something very serious, because virilization in pregnancy either tells you problems in the mother, which could be either adrenal or ovarian tumor, like a luteoma of the ovary, or it could be problem in the child, like aromatase deficiency, which is commonly asked in exam. Maternal virilization during pregnancy due to a fetal problem is placental aromatase deficiency, or P450 oxoreductase deficiency, which is much less commoner, which is also similar to that of aromatase deficiency, the details of which we have discussed already in the previous videos. Then pubertal hyperandrogenism is quite common again, because during the pubertal growth spurt, the theca cells in the ovary will be little hyperreactive, where follicular cells and the granulosa cells will be lesser developed compared to the theca cells, so that they produce more androgens with response to LH. And the LH surges also will be little bit erroneous and erratic in immediate post-pubertal region. That is the reason why some some girls in the post-pubertal time, they can develop this hyperandrogenic features like acne and hirsutism, which will generally gradually resolve over a period of 1 to 2 years. That is also the reason why if the hyperandrogenism is persisting for more than 2 years, there we diagnose a PCOS, because this pubertal hyperandrogenism is so common in adolescent girls that during the pubertal spurt, they develop this hyperandrogenic features like acne and hirsutism. So what are the cause of pathological hyperandrogenism? And also one more point I would like to suggest is the fact that this pubertal virilization is different from pubertal hyperandrogenism. Pubertal virilization is an ominous sign. Again, you have to rule out adrenal ovarian tumors. At the same time, you have to rule out some underlying congenital DSDs like 5-alpha reductase deficiency, to be very precise, where it tends to produce this pubertal virilization. Remember, this complete 5-alpha reductase deficiency girls are not actually girls, they are genotypically males, but they are grown up as females because of the external genital appearance during birth, which is mostly of female type. So these girls, probably they are underlying genetic females, but these girls, obviously, as I told you, they produce this testosterone spurt during puberty, which might virilize the external genitalia, resulting in this virilization during puberty. That's a very important sign of a 5-alpha reductase deficiency. Clear? So you have to be very clear. So what do you mean by hyperandrogenism and what do you mean by virilization? Virilization during any time in life, during pregnancy or during birth or during puberty, doesn't matter, it is always dangerous and you have to evaluate for very serious conditions. Simple hyperandrogenism, sometimes it can be physiological, sometimes it can be pathological as well. So what are the pathological causes of hyperandrogenism? So I can divide into ovarian causes of hyperandrogenism, I can tell adrenal causes of hyperandrogenism, and I can tell much more rarer miscellaneous causes of hyperandrogenism. What are the ovarian cause of hyperandrogenism? The most important top of the chart is the PCOS, which is a very, very important cause of hyperandrogenism. Clear? And it's the most common ovarian cause of hyperandrogenism. Apart from that, we have certain ovarian tumors which have to be ruled out. Usually ovarian tumors will produce virilization, will virilize the females. Remember, virilization after the 13 weeks mark means only clitoromegaly. Remember, only in the fetal life of 8 to 13 weeks, excessive androgens can produce labioscrotal fusion. After the 13 weeks, how much ever androgens you give, they cannot produce labioscrotal fusion. They will be producing only your clitoromegaly. Clear? So that's why I told you multiple times. So this virilization means clitoromegaly. So tumors like arenoblastoma of the ovary, or sometimes even Leydig cell tumors can happen in ovary. So this usually happens in the third decade, early life, but still it happens around the third decade, not in the adolescent life. So they can produce virilization by producing excessive androgens. And next, you can have other conditions like hyperthecosis or maternal luteoma of ovaries, but hyperthecosis is far more common. Hyperthecosis is, you can remember, like an extreme form of PCOS, but even though it's not exactly the same. So it can happen in patients who are having severe insulin resistance, severe metabolic syndrome, or long-standing PCOS. So what happens in these conditions is this combination of high insulin and high luteinizing hormone and high androgens continuously stimulate the theca cells to go for expansion and autonomy, and they do not produce exactly the tumor, but they'll be producing excessive amounts of androgens because of their extreme hyperactivity. And how will you differentiate from PCOS and hyperthecosis? The fact that PCOS never causes virilization, but hyperthecosis will generally tend to virilize the female because of the extreme amounts of androgens they generate. And there are some rarer causes of hyperandrogenism, like your disorder of sexual differentiation. I told you very importantly your 5-alpha reductase deficiency, which tends to produce pubertal virilization of a girl, but they are basically genetically males, XY karyotype. And some DSDs, not all, some DSDs can produce pubertal virilization due to excessive androgen production during puberty. And insulin resistance, severe insulin resistance alone can produce a little bit of hyperandrogen, not necessarily virilization. But remember, PCOS is an altogether different thing. It's an unexplained hyperandrogenism. But severe insulin resistance alone, without a syndrome of polycystic ovarian syndrome, they can develop hyperandrogenism. And what are the adrenal causes of hyperandrogenism? Adrenal causes, usually we think about non-classic congenital adrenal hyperplasia. So NCCH, the moment you call it non-classic always means it happens later in life. It's not going to manifest at birth, because classic deficiencies usually manifest at birth itself, like 20-hydroxylase deficiency. They are present either with a salt wasting form or a simple virilizing form. Or second one is your 3-beta-HSD, 11-hydroxylase, all these things they tend to present at birth itself if they are classic form. But they are non-classic form, they can present later in life as well. So the best example is 20-hydroxylase deficiency, and by default it's the most common adrenal cause of hyperandrogenism. And this 20-hydroxylase deficiency can be easily diagnosed with elevated levels of 17-hydroxyprogesterone. Clear? So similarly, you have non-classic varieties of 3-beta-HSD deficiencies also, which generally tends to be completely self-limiting in nature, which can present later in life, and this is diagnosed usually with the help of elevated levels of 17-hydroxypregnenolone and not 17-hydroxyprogesterone. But in general, we use this delta 5 delta 4 ratio, for example DHEAS to androstenedione ratio, or a 17-hydroxypregnenolone to 17-hydroxyprogesterone ratio, which will give you the diagnosis. And we have non-classic 11-hydroxylase deficiencies also. So non-classic 11-hydroxylase means I'm talking about this 11B1, 11-beta-hydroxylase that is present in zona fasciculata. These deficiencies will have excessive deoxycorticosterone levels or 11-DOC levels. Suppose if these levels are normal and you strongly suspect some adrenal cause of hyperandrogenism, then you can try doing ACTH stimulation test. So because the adrenals will respond to ACTH, once you give ACTH, obviously all these enzymes will be hyperactive now, and obviously if there is an enzyme deficiency, the substrate will start accumulating and that will become obvious. Now the covert deficiencies will become overt deficiencies after giving ACTH stimulation. Clear? So this is how you diagnose a non-classic congenital adrenal hyperplasia. The most common and the most important for exams is the 21-hydroxylase deficiency, where these girls generally present late in the post-pubertal life with hyperandrogenic features like your acne, hirsutism, and probably they might have polycystic ovaries also. I told you 30 to 50% of this 20-hydroxylase deficiency girls with non-classic type may have high polycystic ovaries. That's the reason why I told you polycystic ovaries are a effect of hyperandrogenism rather than just a cause of this hyperandrogenism. Fine. Then next one is the tumors, adrenal tumors. A lot of adrenal tumors can produce hyperandrogenism. Remember, whenever they virilize, remember non-classic type can produce simple hyperandrogenism, which is far more common, or they can even virilize, depending on how much androgens they produce and how much is the enzyme deficiency. But usually these tumors, definitely they will virilize. So whenever you experience a virilization in an adolescent or an adult woman, so you always do imaging. Imaging is very, very important, especially the ovarian adrenal imaging is one of the keys to diagnose this girls with virilization, because there is definite underlying tumor. Then only they can virilize usually. They produce extremely high levels of androgen. So then you have Cushing's, slightly less common, not so common, Cushing's. So Cushing's can be ruled out by doing a 24-hour urinary free cortisol, or alternatively I can do a late night salivary cortisol or a midnight serum or a salivary cortisol. Serum I can do, or you can do a salivary cortisol also. But in general, in Indian subcontinent, we prefer doing a serum cortisol, which is generally done at 11 p.m. to 12 a.m. because that is a time where the ACTH and cortisol will be at rock bottom, and that time if your cortisol is high, it tells you blunting of diurnal variation, which diagnoses Cushing syndrome. So, or some rare causes are there, like cortisol resistance, but generally rare, we don't really consider in routine practice, cortisol resistance. Clear? So these are some of the adrenal causes of hyperandrogenism. But what are the miscellaneous causes? So there are some conditions which produces central anovulation, which are very important. What are the conditions that produces central anovulation, which means it should be either a hypothalamic cause or it should be a pituitary cause. That's it. So most commonly encountered pituitary cause will be the hyperprolactinemia. This hyperprolactinemia, much more commonly it can be idiopathic, or little rarely it can be adenoma, pituitary adenoma, or even more rarely it could be a pituitary hyperplasia. But very commonly it's a idiopathic hyperprolactinema that you will encounter, and because of high prolactin itself, which can suppress the FSH, because of the suppression of the FSH, they can go for your anovulation. Because you have anovulation, the progesterone feedback will be less. I told you anovulation itself will lead to loss of progesterone feedback. Loss of progesterone feedback means there can be slightly higher levels of LH that might result in excessive androgen production. So anovulation itself can produce hyperandrogenism through multiple mechanisms. And hypothalamic causes, lot of causes are there, that itself can result in hyperandrogenism. So there are certain drugs that can produce this hyperandrogenism. The most important of all is the valproate. Valproate is one of the very, very important drugs you should never forget in exams, which can cause hyperandrogenism, because valproate is known to stimulate the 17-hydroxylase in the theca cells, which means they can cause theca cell hyperplasia, and they can produce exactly a PCOS-like picture. It's PCOS is an unexplained hyperandrogenism, but the patient with valproate causing hyperandrogenism should not be essentially called as PCOS, but still they can produce an exact PCOS-like picture with polycystic ovaries. Clear? So that's why valproate should not be prescribed in adolescent girls and girls who are aspiring for fertility, because valproate can induce anovulation. So that is the reason why it should not be prescribed in these young girls, especially who are wanted to get pregnant. And there are some other causes like obesity. Some other miscellaneous causes like obesity is there. Obesity can well produce hyperandrogenism, but please do understand that it is a peripheral cause of hyperandrogenism and not a ovarian cause of or adrenal cause of hyperandrogenism, where because adipocytes have that 17-beta-HSD enzyme, which you have told, if there are more adipocytes, more 17-beta-HSD activity, more conversion of weaker androgens to potent androgens like testosterone. Fine. So how will you define a ovarian versus a adrenal cause of hyperandrogenism? So now I want to biochemically differentiate ovarian versus adrenal cause of hyperandrogenism, and how can I do that? So the basic and the best baseline test that I can do is DHEAS. Then the second test which I can do is androstenedione, even though this will not be that important, and dexamethasone suppression, and your GnRH response. So remember, DHEAS is the most commonly used clinical test and biochemical test for differentiating ovarian and adrenal hyperandrogenism, where in adrenal causes it will be definitely high, whereas in ovarian cause it will be normal. This is what I've been told I've been telling in the beginning itself in the physiology section. Then androstenedione is not that useful. It can be eliminated in both ovarian as well as adrenal causes. Dexamethasone suppression, obviously the adrenals only will respond to dexamethasone suppression because adrenals are driven by ACTH, and obviously giving DEXA will reduce ACTH, and obviously if it's adrenal cause, the DHA's levels will drop after giving dexamethasone. Clear? So GnRH, so ovaries will not respond to this dexamethasone suppression. GnRH responsiveness obviously means it is ovarian hyperandrogenism, but adrenals will not respond to GnRH because ovaries only will respond to LH, and this LH levels can be reduced with continuous GnRH. So once the LH levels reduce, the androgens will reduce if it's an ovarian cause. So that's what we refer to as a GnRH response. So these are the ways to differentiate between an ovarian hyperandrogenism versus adrenal hyperandrogenism, even though the DHA is the most commonly and often the only performed clinical and biochemical test. So now you know all these things. So it's a tedious process to know, but how will you approach a case of hyperandrogenism? What is the approach towards hyperandrogenism? Approach is very simple. First of all, I'm going to see the patients with clinical hyperandrogenism, whether is there any clinical features of hyperandrogenism. The clinical features of hyperandrogenism are not there. I'm not going to do any further workup. There is no need to unnecessarily do testosterone in these cases if you don't have a clinical hyperandrogenism. If I have a clinical hyperandrogenism, then obviously I will be doing serum total testosterone levels. If total testosterone levels are elevated or total testosterone levels are normal, if the total testosterone levels are normal, then I have to do a free testosterone because clinically I'm having a severe hyperandrogenism. So I have to do a free testosterone. If the free testosterone is elevated, then definitely I am having a case of hyperandrogenism, both clinical as well as biochemical hyperandrogenism. Clear? So if the free testosterone levels are also normal, then probably I might be thinking it as a physiological condition and I can just reassure. It's not a true hyperandrogenism. It must be some other cause or probably some racial difference with regards to hirsutism and acne is concerned. So I can just reassure this patient. That is the reason why we have set the threshold for doing this total testosterone. I told you in the FGS score itself. So now I have confirmed it's a hyperandrogenism. Next step is to see whether it is virilizing or not. Even with levels of total testosterone, I can tell whether it is virilizing, or with clinically itself, I can tell whether it's virilizing or not. If it's virilizing, yes, or if it's virilizing, no. Clear? If it's virilizing means definitely next step is to do an adrenal and ovarian imaging, because I have to rule out a tumor here. Because there is a high possibility of grave diagnosis like adrenal and ovarian tumors. So I have to rule out tumors. So in that case, I'll be doing adrenal and ovarian imaging. If not, then I'll be thinking about other virilizing causes, which are extremely rare to be honest. So if it's not virilizing, then I'll be doing some screening investigations for hyperandrogenism. What are the screening investigations? I can do free T4 and TSH levels for ruling out hypothyroidism. I didn't tell you that, but hypothyroidism can produce hyperandrogenism. I'll tell you how. So prolactin levels has to be done, and urinary free cortisol levels has to be done, or I can do a late night serum cortisol as well. And if possible, I can do a 17-hydroxyprogesterone depending on the ethnicity. Certain ethnic groups in certain countries, they routinely do 17-hydroxyprogesterone. In Indian subcontinent, we generally don't do routine 17-OHP. In general, we do only these kind of screening investigations. So why hypothyroidism? Because I did not mention here in miscellaneous causes, hypothyroidism can cause hyperandrogenism as well as it can mimic hyperandrogenism in multiple mechanisms. Remember, especially this primary hypothyroidism. Whenever you have a primary hypothyroidism, you will have increased TSH. And apart from that, why this increased TSH is there? Because this hypothyroidism is going to stimulate the hypothalamus to produce increased TRH. This increased TRH is the main reason why you develop this increased TSH. This increased TSH has multiple effects. Apart from that, this increased TRH can produce excessive prolactin as well. This excessive prolactin can lead to anovulation, because this excessive prolactin inhibits the gonadotropins. They inhibit the FSH predominantly. Because of that, you will go for anovulation. Because of anovulation, you will have reduced progesterone. Because you have reduced progesterone, this reduced progesterone can produce excessive LH, isn't it? Because progesterone is a very important feedback for LH. If you have reduced progesterone, you will have more LH. This increased LH is the main reason why you develop hyperandrogenism. Clear? And similarly, this TSH itself has a spilling effect on the LH receptors. LH receptors in the theca cells. Because TSH, I told you, is alpha subunit of TSH is similar to FSH, LH as well as TSH, which are sharing this common alpha subunit. Whenever you have this excessive amounts of TSH, this is called the spilling effect of excessive TSH, where it can act on the LH receptors of the ovary, which can stimulate the LH receptors of the theca cells of the ovary to produce more androgens, which means hypothyroidism itself can be a cause of hyperandrogenism. At the same time, hypothyroidism itself, clinically hypothyroidism itself can produce coarse hair, coarsening of face, and dry skin, coarsening of hair. So they can itself convert the vellus hair to terminal looking hair-like appearance. So that is the reason why hypothyroidism is one of the strong possibilities of differential diagnosis for hyperandrogenism. That is why I am doing this screening test with FT4 and TSH, prolactin and cortisol to rule out a Cushing syndrome. Clear? So once my screening is positive, depending on that, I'll be doing further evaluation in that particular area. If the screening tests are normal, which means the screening tests are negative, all the screening tests are normal, then I'll be doing DHAS to differentiate between a ovarian and adrenal cause of hyperandrogenism. So if the DHAS levels are more than 700, I'm very sure it's a adrenal cause of hyperandrogenism. So which means I have to do adrenal imaging. If DHAS levels are normal, then I'll be thinking about a ovarian cause of hyperandrogenism. In this case, very commonly I'll be thinking about a PCOS. PCOS, as I mentioned to you before, it should have a normal DHAS. That's very, very important because it's an ovarian cause of hyperandrogenism. Suppose if adrenal imaging is normal, then I'll be thinking about probably doing a 17-hydroxyprogesterone, because if it is elevated, then it goes towards a non-classic congenital adrenal hyperplasia due to 20-hydroxylase deficiency. If 17-OHC levels are falsely normal, then I will be doing other biochemical testing to rule out other rarer forms of congenital adrenal hyperplasia, which are generally very, very rare. So we don't usually encounter these conditions. So these are some of the ways to evaluate a hyperandrogenism. It's a very elegant and a neat approach which I have told. It's very easy. When you study the textbooks, it's going to be very tough. This is the clinical approach that we do in practice, and this must be very useful for your practice as well.